The first step, and one that is often forgotten, is to make sure that you remove the epithelium for at least 1 millimeter on the graft side, that is the flap side, and 1 millimeter on the host side, so that the glue will stick, because glue doesn't stick to epithelium. Then, using a lifter, the adhesions between the flap and the bed are removed, and a lifter is used to dissect between the flap and the bed, and the flap is rolled back. Then, using a 69 beaver blade, all of the cells are removed from the bed, both the peripheral cells as well as centrally. Sometimes you can't actually see the cells, so you have to be very careful to remove them all and sponge them off to make sure any little residual epithelial cells are not adherent to the bed. And then the same thing is done for the undersurface of the flap. This is a very important step, and again, often forgotten or ignored by surgeons. Extremely important, because a lot of cells are adherent to the undersurface of the actual flap. And then again, using a Weck sponge to remove any residual adherent cells to the undersurface of the flap. The flap is then reposited back into place, and irrigation is performed between the flap and the underlying bed. Then it's super important to spend time to make sure that that flap is perfectly positioned and that all of the interface fluid is removed. So that's done both with a special rounded instrument here and then with a Weck sponge as well. And you'll notice that the gutter, that is that little space between the edge of the flap and the bed, is symmetric all the way around, ensuring that the flap is perfectly centered. Now in this case, I'm going to suture the flap down. And the first thing I'm going to do is put in 3 what we call cardinal sutures. And those are placed at the 12 o'clock, the 3 o'clock, and the 6 o'clock positions. That makes it so when I do the running suture, which you'll see in just a moment, that the flap is stable. I'm not going to bore you with the details of each flap. Each suture, but just give you an idea. So the suture is tied down, and now I start the running anti-toric suture. This is going to be an 8-bite suture, which is not the same suturing technique that we use for penetrating keratoplasty. This is used only for special cases of lamellar keratoplasty, such as this, whereby 8-bite suture is placed in such a way as to not induce astigmatism. That's why it's called an anti-toric suture. This is tied down and the knot is cut short. At this point, I'm going to add fibrin tissue glue, and that comes in 2 components, kind of like epoxy, although it uses fibrin and fibrinogen. So the first component is placed, and then the second component is placed, and then I allow about 10 minutes for this to dry. Now here it is 10 minutes later, and the glue is dry and the suture is in place. Then I'm going to put a soft contact lens on, which is going to stay in place for a couple of weeks. It takes a couple of weeks for the glue to dissolve under the contact. Contact lens always placed sterilely, and make sure that it's positioned well. We then follow the patient closely over the next weeks, and the suture is removed generally 3 to 4, maybe 5 weeks later. And although not a guarantee, this is an excellent way to ensure that epithelial ingrowth does not recur after it has already recurred a number of times. Thanks for your attention.